Hi, this is Matthias Friedrich for CVI Plus, and I'm here with Professor Thoralf Niendorf from Berlin. He is the director of the Berlin Ultra High Field Facility and also organizer of the pre-conference workshop as a joint venture between ISMRM and SCMR here at the 2013 SCMR sessions. So, from your point of view, Thoralf, what do you think were the highlights of the high field workshop and the coolest directions of this area?
First of all, it was pretty much exciting that so many people attended this meeting. We got more than 210 registrations.
Oh wow,
which is
that's much more than last year, right?
That's more than last year, and it's pretty much heartening and encouraging when you look at high field MR, because it has been considered as a kind of exotic discipline so far, but more and more people are moving into that field, and it seems that 3 Tesla becomes mainstream.
Yeah, so what is high field now in these days?
Previously, 3 Tesla has been considered to be high field, and 7 Tesla has been considered to be ultra high field. But with all the progress being made in that area recently, people start to move to calling 7 Tesla high field the new high field scenario, while the upcoming 10.4 Tesla and 11.7 Tesla are more and more considered to be ultra high field.
So where do you see the most important applications of, let's say, high field defined by 7 Tesla or higher?
We can also talk still about 3 Tesla
because
this is very relevant for clinical use. In general, I think all the applications which currently suffer from sensitivity or signal to noise ratio really benefit from moving to higher fields, because there's a sensitivity gain intrinsic to high fields. And I would like to include perfusion-weighted imaging, delayed enhancement imaging, and also black blood imaging into this kind of applications.
And the problem of artifacts with motion can be handled, you think?
Motion is not an issue at all at high fields and also ultra high fields. There needs to be some technology developed, but today we have been basically able to demonstrate the progress by boosting the spatial resolution by almost an order of magnitude when you move, for example, from 1.5D to 7D. So just to give you an example, as far as I can see in today's clinical practice, spatial resolution of something like 2 by 2 by 8 or 6 millimeter has been used for standard routine imaging, including cine imaging, and this is down to 1 by 1 by 2 or 4 millimeters at 7D. And we had, during that meeting, we had a keynote lecture by Warren Manning, and he basically focused on what it's been needed for clinical imaging. And he basically said what he needs is spatial resolution, spatial resolution, spatial resolution.
Yeah. So what are you, from your point of view, the low-hanging fruits? So where are clinical applications where you say in 2013 it makes sense to primarily use 3 Tesla or more for inpatients? Which indication do you think are the most?
For sure, I would say that perfusion-weighted imaging falls into that category, delayed enhancement imaging, and bolt imaging. So sensing or probing for blood oxygenation, because the bolt contrast runs with the power of 2 with the field strength, and here it would even make more sense to go to higher field strengths.
So, as far as I know, a coronary angiography may also benefit from higher field strength. So doesn't this sound like a good package for ischemic heart disease if you can look at oxygenation, perfusion, and eventually the coronary angiography to actually plan the therapy then? But the problems with SSFP imaging, you think, are not an issue then in these patients?
No, the reason why SSFP has been used as a gold standard at lower fields is that it provides rather nice blood myocardial contrast, which makes it easy to delineate the endo and epicardial borders. At 70, you can achieve the same quality with a good old flash imaging techniques with the same contrast.
Okay,
so here I don't see any problem for SSFP imaging.
So last question, what is the hottest thing you are up to in the next year or two, as far as you can talk about it?
we are looking into ways in order to further drive bolt imaging at 7 Tesla, and we have been recently published a paper where we showed changes in T2 to star over the cardiac cycle,
Wow.
which is pretty much exciting, and
Yeah.
it bears a lot of potential to be further explored. And we also think that T2 star weighted techniques might be a way or might provide means in order to study myocardial microstructure, including assessment of myocardial fiber structure. So we think,
Tractography, yeah.
or tracking,
Yeah.
we think that in addition, or unlike the fusion tensor imaging, this technique is less sensitive to motion and might provide means for myocardial fiber
Okay.
tracking. So
Okay.
Boyd and T2 star weighted techniques
Okay.
are a hot topic. But since I'm a physicist, I'm also working on projects which are a little bit off the beaten track. So we have been using, or we are using, and we are driving research into using MR for targeted RF heating.
As a
Where you can
therapeutic?
basically heat up focal areas. At 1.5 Tesla, these areas have a size of 50 centimeter.
Not really practical?
Not at all. At 7 Tesla, the size goes down to a centimeter.
Oh,
And at 14 Tesla, the size goes down to a few millimeters.
wow.
So we think that ultimately this might provide means to provide an alternative for
Ablation.
today's conventional electrophysiology and
Yeah,
ablation.
excellent. Yeah.
And we have demonstrated that already in simulations and early experiments, and it's going to be very promising.
Okay. Thanks, Thoralf. Good luck for that, and thanks for stopping by. This was Thoralf Niendorf, the director of the Berlin Ultrafield facility, and this is Matthias Friedrich for CBI Plus.